Welcome back, everybody. So it's 11 o'clock. I hope you've had a chance for a break. Hope you were able to join us in the first session. Thank you for all the questions that have been coming in. There's some really great chat. Really lovely to see how someone's putting a question in and someone else is able to answer it from their experience. So thank you very much and keep doing that. So for this session, we are keeping our fingers crossed that Andy Burnham is going to join us. He's doing a radio programme and is going to come to us straight from that. Fingers crossed everything works. But there is a chance that it won't work. So we have about 3 plans for this session. And if I'm honest, it's called Winging It. But we're going to have a great session with you anyway. But I just thought we'd be transparent and upfront. So what we're going to do first of all is we've got an interactive poll. So we'd like to hear from you. So Andre is just going to put a slide up on the screen. And that's got a QR code, or you can go to the menti.com site and it will show you the code to put in. And so here you go, you can see that now. So if you just put that in and start doing the poll.
Keep it on for a good time.
So hopefully you are able to scan the QR code, or you're able to go to menti.com and put this in the poll, and we will start to understand what your concerns and your challenges have been and what the unexpected benefits have been. So we'll just leave that up for a little bit longer. And if you've got questions that you want to ask Andy Burnham, then start putting your questions into our live Q&A and we will start to publish those. I'm pretty sure some of the questions from last time are ones that we're going to bring out. So we'll just give you another 30 seconds. We'll leave that slide up for a little bit longer so that you can keep getting onto the poll. And Sam, we were having a look through the questions from the last session, weren't we? And we've pulled out a few of them because we didn't get a chance to answer everything. But perhaps, Sam, I can go over to you now. Have you got a question that you'd like to ask one of the panel from the last session?
Yeah, actually, it was a question from Julie Lomas, specifically for Emma. And she says, hi, I would like to ask Emma from Bromley by Bow where they obtained all the contact details for the residents from. When she said about not waiting to receive referrals, but to reach out to people. Where I work, I'm limited to receiving referrals mainly from GP staff and would not have the knowledge of need or the access to contact details to be able to reach out. Emma.
Yeah, great question. Thank you so much. So I think a couple of things. One, our social prescribing team broadly is embedded within primary care, so our GP practice network, and also within the community centre. So this is really kind of going to where people are. So sometimes it's about accessing, for example, ESOL classes and suggesting contacts via that way, or it's going to different groups that we used to run when we were obviously able to meet face to face and contacting those people who we already know would be in need of support. Also through our GP practice, we are able to tack social prescribing onto sort of usual activity, so things like recall for chronic conditions, but that is honestly based on really strong working relationships with the GP practice. We also link in with not just clinical staff within the GP practice, but also our kind of admin and frontline staff as well. So our receptionists that we call patient assistants, and we've got a lot of contacts via that way as well. So it is really through networking, and it is really through kind of those personal relationships. And I would say, yeah, investing in those is really worthwhile.
Thank you very much, Emma. Stuart, a question for you. This comes from John Holland of Solver Care. And he asked the question, how is it best to build social prescribing with GP practices that are reluctant to engage?
I think that's a challenge for us all, to be honest. I think what's important is that it doesn't have to be GPs who lead social prescribing. I would be surprised if you if you go to any actual practice, that you can't find someone in a leadership role who understands and believes in the themes of social prescribing. I think it's also worth knowing that actually for ourselves, although social prescribing has been really wonderful for our patients, it's not quite all selfless altruism. And what we found in with the cohorts of people who engage with social prescribing is that they actually use our GP services about 40% less. So they request 40% less appointments. And so there is, I think, good evidence that actual social prescribing can reduce demand on GPs, and that's actually, I think, should be a fairly easy sell. But it is difficult. I think it's about finding the willing leader in a practice, and I would say that in most practices you would be able to find that individual.
Yeah, I must say what we've discovered with GPs is go and talk to them, find out what their problems are, and create a win-win scenario. So on our referral form, for example, we have a little box you can tick around repeat attenders. And this is the most challenging patients for GPs. And if you can be a solution to that, that's enormously helpful. We might just have time, Mari, for one more question in this arena. And I'm going to tie all the questions together because it's a consistent theme in all the previous questions, which is basically money. You know, how are people finding resources at this moment in time? Stuart, Amy, Emma, anyone want to answer that? Actually, what's the resource? How have people come up with more money? What sort of things have they done? I mean, our local authority have created a helpline jointly with us, which is fantastic. That's a fantastic resource. But any thoughts?
I'm happy to come in, Sam, if that helps, just from some of the things that I've learned. So I've heard some great examples recently of areas where places have worked together with their council and their community funds to create a local giving fund, which then charities and other community groups can access for support to provide stuff and activities. Collaborative commissioning as well. There's quite a lot of examples where local authorities and clinical commissioning groups are working together to try and fill gaps. Yeah, so there's just a couple of examples of how people are trying to overcome the funding challenge at the minute.
Yeah, ironically too, actually, what we've discovered is, interestingly, there is a lot of people who have got a lot more money because they don't have the opportunity to spend it. This is a fantastic opportunity to ask them to gift aid it. So at Bromley by Bow, we were due to have a charity dinner, a fundraising event, and we've gone back to everyone and say, would you turn that into gift aid? And they've all said yes. So ironically, an opportunity out there. Mari, where are we in terms of Andy? Or should we carry on with the question?
Well, we are still waiting for Andy to arrive, but I wondered, Andre, could you put up the live poll slides, and we'll see who's with us and what that looks like at the moment, because I'm really interested to see what the challenges are. So what sector do you represent? So it's hard to see on the bottom, so I'll just go through that for you. So VCSE is 26%. We've got primary care and GPs and community, 23%. We've got local authority, and public health and adult social care 9%, 16% others. I'm sorry if I didn't get all the categories on, it starts to become really difficult. So we've got a spectrum of representation. So Andre, next slide, we'll see where people are from. Oh, that's which sector do we represent? Are we able to see, Andre, where people? Okay, lots of people from England, not a surprise. Welcome to the people from Australia and New Zealand. It must be very late at night with you at the moment. And welcome to the people from Asia. I wonder if that's our friends in Singapore. And great to see people from North America and Europe with us as well as the home countries. So I think the next question is maybe about challenges or concerns. So let's have a look at that. What's happening at the moment? So the biggest challenge faced relating to social prescribing in your scheme or your organisation, and we can see, is funding, and it's always been funding in the last 5 years. And if Andy Burnham joins us, it'd be really good to get his perspective on this sort of political aspect of social prescribing. Engagement, knowledge, connecting, time, COVID and awareness. So maybe Amy, you can just think on that. I'm going to come back to you in a minute of whether this matches up with what you found in the Southwest. Andre, would you move us on to the next slide, please?
I am here, Sam, if you can hear me. I don't know if you can, but I have joined.
Welcome, Andy. Just lovely to have you with us. Just bear with us whilst we can have a look at this.
Sorry to interrupt.
No, very welcome. Very glad to have you with us. So we're just looking at what the main concerns are about social prescribing, and this is our audience at the moment. It's quite a few hundred people, representation from quite a few continents actually. And the main concerns about social prescribing are funding, sustainability and capacity and support and engagement. And finally, Andre, can we look at the unexpected positives that have come out of social prescribing in the last year during the pandemic? So community innovation partnerships, collaboration, networking, and that's really quite good to hear. That resonates with what I've picked up on the ground as well. And actually social prescribing works when we have good partnerships and community at front and centre. So Andre, thank you for that. We'll take those slides off now. And I'd just like to give a really warm welcome to Andy Burnham. So Andy, I'm just going to do a little bio and then I'm going to bring you in, okay? So Andy Burnham was elected Mayor of Greater Manchester in May 2017. So you've had a few years in the job now, haven't you, Andy? And you've been responsible for shaping the future of Greater Manchester, and your priorities include ending rough sleeping, transforming Greater Manchester into one of the greenest cities in Europe, and making Greater Manchester a great place to live, get on and grow old. And you're working closely with Greater Manchester Health and Social Care Partnership to improve health and wellbeing for the 2.8 million people living in Greater Manchester. And we all know that you have been a long-standing advocate of health, social care integration and inequalities and improving access to mental health services. And before being elected into your current position, you have held quite a few ministerial positions, haven't you? You've been positions in the Home Office, Department of Health and Treasury. You've been Secretary of State for Culture, Media and Sport before you returned to Health, Secretary of State for Health in 2009. So Andy, you have this amazing perspective from lots of different angles that I'm really looking forward to hearing from. And just from the last session that we had, we've opened the conference and we've just been unpacking what the issues are with social prescribing in the pandemic, how people have responded, how social prescribing has responded. And we see that the benefits have been the collaboration, but actually there's quite a political issue around sustainability and funding. So perhaps I can hand over to you for a quarter of an hour now, and you can share your thoughts with us, and we'll finish with about 10 minutes of Q&A. So Andy, over to you.
Sounds great, Marie. Morning, everybody. Thank you so much for having me along here. You say I've always been a big advocate. Well, I learnt it all from Sam Ebrington, actually, when I visited Bromley by Bow, I think some 10 years ago or more, and saw a vision for social prescribing or health at the heart of the community. And it's great to see Sam this morning. So I have been on a bit of a journey, I guess. You've read my CV out there. Clearly never done a real job, as you can tell from all of those political appointments, but I have learnt a lot along the way. And I'm really honoured, actually, to be giving this address at the 3rd International Social Prescribing Network Conference. And I think we've been invited because it would have been at the Lowry Theatre in Salford in a more normal world. And I know you're going to be hearing throughout this week from some of our wonderful networks in Greater Manchester, from Manchester, Salford and Stockport, in terms of what they're doing. So we're really grateful that we have a Greater Manchester flavour to this conference. If you can imagine that other world that we might have been inhabiting, you'd have all been sipping a glass of wine outside one of the Lowry's theatres now. If wine is allowed at a prescribing conference, I don't know whether it is or not. You'd be taking a big gulp of medicinal Salford air as you're looking out across Salford Quays, across the water, lifted by the buzz of Media City. It's a world, hopefully, that's coming back to us soon. But we're really grateful that you were going to come to Salford, and we hope that we can at some point bring this conference back physically. And the reason why we're kind of honoured is, I guess, we pride ourselves on being the UK's home of radical forward thinking. Manchester has always done that. If you look back at the history, radical kind of social reform, and I would say social prescribing fits into that category. It's time to kind of rethink how we build health in our communities coming out of the pandemic. And the big point I would want to make today is social prescribing's time might just have come, and we need to try and make it so if we're to respond properly to what has been revealed to us all, not just here in the UK, but I'm sure to colleagues, international colleagues, as well during the pandemic. A year ago, on the eve of the pandemic, I was in London with Professor Sir Michael Marmot, launching his 10-year review of his report on health inequalities. And the reason I start with that is because it was something of a premonition for what was about to happen. Michael, in his 10-year review of his groundbreaking and original report, found that life expectancy had stalled in the UK for the first time in 100 years and had actually gone backwards amongst certain groups, particularly women in the north of England. And that was obviously before anything that we've seen in the last 10 years. And it's quite clear that in Michael's report that it's lifestyle, it is work, it is housing that can either build up your health or it can damage your health. I think the Health Foundation, in a report in 2017, made this point in a different way, that I think health is 10% influenced by formal healthcare services, but 90% influenced by all of those other wider factors that I've just mentioned, those determinants of health. So Michael Marmot was saying last year how health had gone backwards in our poorest communities because of the insecure, low-paid nature of people's work, the poor quality of housing. And now COVID-19 has ruthlessly attacked those vulnerabilities, and the death rate in our poorest communities is more than double the rate in some of our more affluent communities from COVID-19. So I think the important thing for me is that we don't just sort of move on from the pandemic because it's been so awful, and we don't take time to understand what has happened. I think a conference like this needs to look very carefully at what has happened. We have in Greater Manchester right now if we had have been welcoming you to Salford and to the Lowry Theatre, we would have been telling you that, you know, we are at a point again where we have a higher case rate than the England average, and we've had a stubbornly high case rate all the way through the pandemic. And why is that? It's because of those structural inequalities. It's because of the high number of people who've been out at work all the way through the pandemic, because the support to self-isolate has never been properly in place. It's because housing is such that it doesn't allow people to self-isolate safely and with the space that they need. So it's been we've kind of come to a point, but perhaps here's to take it more positively. Perhaps these last 12 months have created a moment where the world and the UK can start to think differently about health. I think we've always had a mindset in our country that the NHS will solve it all, and it's all about reactive medical intervention that, you know, is what we need to look after people from a health service point of view. That's been the sort of post-war mentality, I think, about health. But maybe, just maybe, the year we've just lived through might make us think differently. So let me just point out a few ways in which that might happen. Firstly, I think we can see more clearly where health is poorest. I've just touched on that. The map of the UK last year, when we had the local restrictions in place, very clearly was a map of the poorest parts of the UK. And I think we can understand more clearly now that the things that what Michael Marmot was arguing were kind of made visible to everybody, and it is very linked to inequality. So that's one thing, and I think people can understand that now. And if levelling up as a concept that the UK government is pushing, surely it has to start. You have to level up first the places of greatest need, not scatter funding to a random list of politically interesting places, but actually focus funding on the places where the need is greatest. And I'm just a passing comment on the budget there. I won't go any further than that. So that's one thing that maybe the last year has shown us. The second is that social behaviour impacts health. I think the public understand that perhaps a little more clearly now. Social distancing as a concept needs to be built upon, and to other forms of social behaviour as to how you both protect your health, but also potentially then enhance your health. So the notion that behaviour, social interaction impacts health, I think, is more clearly understood by the public. I think we've had a changed way of delivering services, more digital delivery of services, and more informal delivery of services, which has sort of broken away from some of the norms. And we've seen that in primary care in Greater Manchester. That's a positive as well. And lastly, again, back on this point about lifestyle and behaviour, I think the public have really understood, particularly in lockdown, how exercise and access to green space can change the way you feel instantly. And I think there's something here for social prescribers to think about in terms of how we bring the public on board with what we're trying to offer. We often, the point I'm making is, we often sell the benefits of physical activity in terms of long-term benefits to your heart or your weight or diabetes or something like that. We often sell it. Physical activity is often sold with respect to the benefits to physical health. I think we need to rethink that and sell physical activity predominantly with regard to the benefits for mental health, because I think the British public, and possibly more widely around the world, have understood how exercise instantly lifts mood. It instantly makes you feel better. It instantly makes you better able to cope with what the day is throwing at you. And I don't think we sell social interventions in that way. You know, they provide an instant hit, if I could put it that way, in a way that pharmaceutical or medical interventions sometimes don't. But certainly physical activity, exercise, access to green space, I think lifts people's mood straight away. And I think that is something that's possibly better understood coming out of the pandemic. So I guess what I'm building to, Marie, is there's a big opportunity in front of us here when you think about public understanding of health in terms of how it's built in communities, how behaviour affects health, the kind of beginnings of change in the way primary care was delivered, has been delivered, and also the linkage of exercise and outdoor activity to mental health. I think all of that creates a massive opportunity for social prescribing coming out of the pandemic. I just checked with my team in Greater Manchester, because we've been going great guns on it, to be honest. I think we would say that we're the capital of social prescribing in the UK. Other places may have a claim to that, but Manchester never knowingly sells itself short. We always claim to be the top of the league table in anything, be it football, music, or whatever you like, and we're going to make this claim on this issue. I'm sure Sam is ready to fire back at me anytime soon. But all 10 of our boroughs are now have active social prescribing networks. 8 in 10 GP practices are referring patients to social prescribing options. We have 200 social prescribing link workers on the ground in Greater Manchester, which is fantastic. However, when I was preparing for this conference, I asked my team, but had all of this gone a little bit in reverse last year? Because obviously the focus has been on medical and pharmaceutical and PPE and, you know, all of that stuff. And actually, I was really pleasantly surprised to find out the opposite has been the case. Tameside, one of our boroughs, has seen a doubling of social prescribing referrals over the last 12 months. Stockport, who you will hear from on Friday, had a record month in April last year, the lockdown month, and that is, I think, really encouraging, and it's something really positive to build on. So that infrastructure is there. It's becoming more and more used and understood. It's working. I think people are buying into the idea that a prescription for medicine is not the best thing you can give to somebody if they turn up asking for help. I think that is becoming more and more understood. But let me finish, Marie, on the big challenge to all of that, which I think was coming out in the presentation that was being given as I joined, and it very much seems that it's a global phenomenon rather than a UK phenomenon. It's the delivery infrastructure, it's the sustainability, it's the funding. You know, how do we create a funded social prescribing infrastructure that is rooted in our communities, and particularly delivered through well-supported voluntary community and charitable organisations within our communities? And I think that is the biggest risk to everything that I've said today, the opportunity that I've described. The voluntary and community sector has been hit extremely hard during the pandemic. Normal fundraising activities have been suspended, or in some ways completely derailed, and there isn't much talk at a national level. There wasn't much reference in the budget yesterday to the struggles of the voluntary community social enterprise sector, and of course that is the delivery infrastructure that we need to enhance if we're to make social prescribing a reality. So that's the challenge, and I think the challenge for health services here and around the world is, how do you unlock in a safe way some of the funding that is currently trapped in medical prescribing and allow it to flow into social prescribing? And how do we develop a different relationship with the community, voluntary and charitable sector, moving away from a relationship that's often based on project funding or annual funding to one of core funding, where the sector is a long-term trusted partner in the delivery of social prescribing referrals in any given community. And I don't think we've yet cracked that, you know, that kind of steady state for social prescribing, where, you know, we can build that infrastructure and there is a funding flow that supports it. In Greater Manchester, because of the devolution deal we have, I think we have a bit more freedom and a bit more latitude to prioritise this and build up our system. But I think what we need to do is work with you all to say, well, how do we kind of take this learning and apply it more broadly, as the government are looking at its latest health service reform with the current white paper. Health to finish on this point, surely we all understand this more clearly now. Health is built in homes. Health is built in families, it's built in workplaces, it's built in communities, or it's not built in those places. And this is the point, isn't it? If you want to level up people, communities, you've got to start with that understanding and then build from there. You've got to recognise that a health service that is about reactive treatment will struggle more and more in the 21st century if that is our first answer. And not just from an ageing perspective, but because I think personally there is a mental health crisis following in the wake of this pandemic. I think the damage that has been done to our communities is more profound than we realise. You know, the attention at the moment is all on getting through, you know, getting the vaccination done, and that's where everyone's kind of focus is. What I don't think we're seeing is the very severe damage that has been done to people's mental health and well-being coming through, including the mental health and well-being of our young people and our children, which I think is also extremely profound. And attention really needs to turn to that, and needs to turn to that quite quickly. And we would say in Greater Manchester, you've got to take the health service out of its silo. You've got to start from a place-based perspective. You've got to link the health service to other critical public services that councils provide, that other public services provide. You've got to build from the bottom up. You've got to make social interventions your first offer to the public, not an afterthought or something that you might eventually get round to. You need a structure for social prescribing. You need to fund it. You need sustainable organisations as equal trusted partners in the mix. I think we know now what we need to do. The question is, are we going to have the funding to help us move from where we currently are to where we need to be? But I think you will see no shortage of inspiration from what's going on in Greater Manchester this week. We really want to play our part with you to build this network nationally and internationally. I am personally convinced it is the right answer to 21st century health challenges. Social first. You know, if we are to fulfill the World Health Organization definition of health as a state of complete physical, mental and social well-being, not just absence of disease or infirmity, then I'm afraid you have to put a social model of support for people at the heart of everything that we do. And here in Greater Manchester, we want to work with you to make that case, win that argument, and actually truly raise the level of health in this country and our poorest communities coming out of this pandemic. I'll leave it there, Marie, and hand back to you.
Thank you very much, Andy. Thank you so much for your thoughts there. I found myself nodding away, and I've been publishing the questions in chat, and I'm just going to say, Helen and other people that are on our panel, can you publish the questions? Can you read through and publish for me whilst I'm just chatting with Andy? So there's a couple of things I think, you know, you have such a unique perspective, Andy, from your different roles. I think there's two themes that have come out quite a lot. Number one is it's great to say all of this, isn't it? It's great to say that we want to do all of this. How do we actually unlock that core funding? So I've been saying for about 3 years, we have to bring the different departments together, and they all need to put money into the pot to have core funding, because the outcomes of social prescribing go back into the community. They go back to the determinants of health. So it's not just for the NHS to fund, but the NHS have put money in for link workers, but where's all the other money? And link workers are on very short-term contracts, so there's no sustainability there. You've talked about the funding crisis in the voluntary community social enterprise sector. So I'm going to give you two questions at once, but the first one is, what's the next step that we take together to really now take that next political step forwards to get that proper buy-in that's talked about, but I'm not seeing it yet? And the second one is really about children and young people, and your thoughts on what we could be doing there. There is growing social prescribing into that area. So what do we need to be doing for children and young people to really stave off the crisis that you talked about that is already happening, along with unemployment crises for adults? And, you know, how do we crack this once for all? We're on a turning point now, aren't we?
Yeah. Well, thanks, Marie. It's obviously a challenge, isn't it, given where we find ourselves? But it's got to be the most cost-effective way of building health, hasn't it? To start with that broader view of the determinants of health. We've got to win that argument about health inequalities coming out of this. We currently have a Inequalities Commission in Greater Manchester led by Kate Pickett, about to publish their work. And I think all of us in our different ways have got to not let this, what's happened, go, if you like, you know, not just let everybody move on from the pandemic. We have to expose what's happened and come up with credible answers to what might make things better, to build resilience in people and places where those people and places have been most damaged, so that they are better prepared for the next health challenge that comes along. And to do it politically, I think you've got to start with levelling up. I mean, how do you level, if you really to do that, what that is saying, how do you do that without building the community capital of the places that have, you know, have lost the most? You've got to start at that level. Just parachuting in sort of infrastructure, random infrastructure to those places doesn't level them up. What levels them up is, you know, building, as I say, the social capital of those places. Now, I don't know whether that argument can be won nationally, sort of, you know, in the short term, with all government departments chipping into a levelling up social prescribing sort of initiative. It could be, but I don't know. In the absence of that, I think what you've got to do is get enlightened GPs, many of whom are joining this call today, to sort of almost become agents of change, really, within their communities. Because I think GPs do have the ability to, if you like, stem the flow of spending into the pharmaceutical industry and increase the flow of spending into the local community and voluntary sector. I think GPs can work with bodies like ours at the Greater Manchester level to speed that change up, give confidence to those enlightened agents of change who are prepared to do that. So I think the first stage of change might be more in building this network, building those advocates, and then showing to government the evidence base that comes, particularly in the communities that suffer from the poorest health. I think we've learnt in the pandemic that actually the public sector needs to change without waiting to be told to change from central government. And what I mean by that, Marie, is we've been in the business of providing more informal support during this pandemic, everyday support, casual support, through the community hubs that our councils have set up. And that links very directly actually to the social prescribing efforts in those same communities. The same organisations have been linked to the community hubs who also provide social prescribing. I think the public sector spends a lot of money getting trapped in statutory assessments, needs assessments. There's a lot of bureaucracy goes into that stuff, and not enough into upfront, everyday, simple support for people and communities. And I don't think we need to wait for permission from Whitehall to have a big fund to do that. I think you can move funding on a multi-agency basis into more of that type of informal everyday support. And certainly the most enlightened chief executives in Greater Manchester are already saying that's what we should do. You know, we should keep the community hub infrastructure coming out of this. In terms of young people, I think we need to particularly rethink the offer for young people. We do a survey of teenagers in Greater Manchester. It's called our Life Readiness Survey, and it's just come back, the results. These are year 10s, 14-year-olds, 6,000 of them in Greater Manchester. You won't be surprised to learn they are reporting a significant dip in levels of hope and optimism for the future. A worrying number of them talk about not having online access, not having adequate mental health support. There is a very big call from them for a curriculum for life. I don't think there's a sense that they're getting prepared for the life skills that they need. I think social prescribers need to give some thought to this age group, particularly now, given everything that's happened to them in the last year. I think they need more informal online mental health support and counselling services. We've stood some up in Greater Manchester in the pandemic. I was amazed in this survey to find of 6,000 14-year-olds in Greater Manchester, 50% of the survey was aware of the online mental health services. I couldn't believe that. I thought that I was expecting 5%. 50% were aware of those services, and that tells me something about unmet need that is out there. So innovating and rethinking how we reach that age group, teenagers, people in their early 20s, I think is an urgent priority.
Thank you very much, Andy. I think the one thing, we're running out of time now, but the one thing I think, if I've got the feeling right from link workers, is that they are the ones that are meeting all the different needs that have been, where the focus is on vaccination. Actually, it's the link workers that uncover those complex needs, whether it's in children, young people or adults. So they are seeing the reality on the ground, and I think the literature hasn't always measured and shown the outcomes around determinants of health as much as it has around straight health outcomes. So I think that's definitely something that's already moving in that direction. I think your thoughts really take it forward. So I hope that people that have been listening to you talk will now feel a little bit more galvanised and confident to think, yeah, we're just going to make some decisions. And I really hope that we can unlock that money from health into community, because community is at the front and centre of all of this, isn't it?
I think, Marie, just to finish, I realise you want to move to the next session. I think for the first 21 years of this century, we've been running a 20th century health service, haven't we?
Yeah.
The post-war health service that we created has been stuck in a treatment mentality. And we understand why, because these things are really hard to change, but it has been. And what we've seen is that treats health very effectively, and the NHS has coped amazingly with everything that's been thrown at it this pandemic. But what it hadn't done is put communities in a position where they were ready to protect their health in the face of a pandemic. It has not done prevention, has it? Because that is obvious, because it left lots of people were left exposed. So if ever there was an opportunity to rethink health and health services and health promotion, surely it is now. And I think this should be the moment where we move to a 21st century healthcare, and that has got to be about the whole person rather than just a medical way of thinking about it. Rather than the patient, it's got to be about the person, and it's got to be about that wider holistic approach to supporting people's health and promoting health at the first stage. And yes, a focus on the early years, 0 to 4, before kids even get to primary school, but also a focus on those teenage years. I think these are the moments where health is built in lives, and that's what Michael Marmot's told us. And I honestly believe we've got to move this system now decisively in a 21st century direction, prioritise mental health much more than we've ever done before, and prioritise social interventions, because they in the end build health and they prevent the need for costly spending on ill health. But I do think it's a whole public sector endeavour as well. The health service can't do this on its own. The health service has to get out of its silo. It has to link with councils. It has to link with housing departments, police, fire. I always make the point that Nye Bevan, when he created the NHS, was Minister of State for Housing and Health. And the link between those two things has got lost over the years, and we need to get back to that holistic view of building health in communities. So if ever there was a moment to do it, surely it's coming out of a global pandemic. The call should be now for a 21st century health service in this country, whole person, preventative, and you're the vanguard of this. Your network is at the vanguard of that, and all power to your elbow. We'll always be here to support you in Greater Manchester, and yeah, thank you for giving me this opportunity this morning.
Thank you so much, Andy. I'm so grateful for you taking the time as well, and we will make good on that offer that you've just put out there. We'll come back to you and definitely work with you more. So I'm going to wrap up now. I'd really like to thank Sam for stepping in and chairing with me at short notice, and Emma Cassell for presenting with him, for Amy Cole and Stuart Smith who've been on and presented in the last session. And I feel like hopefully people feel galvanised already, and it's not even lunchtime. So we are going to end this now. There's been some great questions. We're going to get all the questions and we'll come back with answers to those. The next session starts at 12 o'clock, so go and get a quick break and grab a bite to eat. You're in breakout sessions next, so you've got one of 4 things to choose from. We've got a great children and young people's session, so actually if people are interested in that aspect of social prescribing, they can drop into that one. But equally there's 3 other great ones. So goodbye for now, see you in the breakout sessions. Andy, thank you once again.